my great pleasure to introduce Dr. Gillespie, who is an associate professor in radiation oncology at the University of Washington. She has an MPH from Harvard's T.H. Chan School of Public Health, is a faculty member at the Hutchinson Institute for Cancer Outcomes Research. She's a clinical trialist and an implementation scientist focusing on both developing and ensuring access to evidence-based treatments for patients with cancer. She's a principal investigator of a phase 3 cooperative group trial. Work is funded through the NCI, Agency for Health Care Research and Quality, and National Comprehensive Cancer Network. And it is my great pleasure to invite her to speak today to you all. And her title is Preventing Skeletal Events Among Patients with Bone Metastases and Emerging Evidence for Early Radiation Therapy and the Importance of Prediction and Prognosis. So, Erin, I will hand it over to yourself. Thank you so much.
Great. Yeah, thanks so much for having me. I'm going to talk today a little bit about a little background to this project, and then the evidence from our phase 2 trial that we've published, and then the ongoing phase 3 trial, and then, as she mentioned, an implementation science person, kind of my perspective on the importance of really predicting risk, and then also understanding a patient's sort of life expectancy or prognosis, and how these things may need to or should factor into how we treat our patients with bone mets. So this group, I'm sure is very familiar with the existing evidence for radiation for bone metastases is really for symptomatic use. Our hypothesis started when we were recognizing that lots of patients were being hospitalized with significant pain and complications of the bone mets. And when you looked back on imaging, there was evidence of these specific lesions at least 4 months prior. So, could we use radiation early as more of a preventive strategy? Which is really kind of one of the first studies. I think we talk a lot about prophylaxis of palliative uses, but I was excited this was one of the first opportunities we had to really test that hypothesis. So a lot of trials suggest that bone modifying agents like bisphosphonates, denosumab reduce bone pain, skeletal morbidity, and may even extend survival, but are often underused for various reasons. But those trials helped us give us the idea that maybe skeletal related events as a composite endpoint would be a valuable outcome to measure for using radiation in this setting, where skeletal related events include pathologic fractures, spinal cord compressions, surgery, or radiation for pain. So we ran a phase 2 trial, and this was just a 1-to-1 randomized trial of high-risk asymptomatic bone mets. Patients were stratified by any solid tumor, breast and prostate versus other, and then really had to have it. This was defined as widespread metastatic disease in order to really not overlap with the oligometastatic trials primarily. And then they could have up to 5 lesions, of which high risk was sort of predefined by some evidence, some expert opinion, but sort of bulky lesions in certain locations like the hip, long bone, and junctional spine. And they shouldn't be complicated, so no prior radiation, no prior cord compression, that sort of thing. And the primary objective was really this composite endpoint of skeletal related events. So we enrolled 78 patients over a couple-year period. I was at Memorial Sloan Kettering Cancer Center at the time, and became kind of the head of our Cancer Alliance for Radiation Oncology, and was able to get this trial opened toward the end of the study in 2 other more community-based sites, which proved that we could do this, and they actually enrolled very rapidly in those 2 sites, in particularly the one in Miami, to increase kind of both show feasibility and of the trial, and potentially increase generalizability of this phase 2. These are just showing that the arms were balanced on things that we planned for, like the type of cancer was about a quarter breast, a quarter prostate, a quarter lung, and then everything else. And then The other important to look at the ECOG performance status was mostly 0 to 1. We actually didn't even, we kind of looked at bone modifying agent use retrospectively. It wasn't sort of a predefined plan, but those were equally in use at the time the trial started, about 50%, which is kind of what a lot of the US and other sort of international data show that, almost every patient with bone mets should be on them, except for maybe castrate sensitive prostate cancer, but they end up not for a variety of reasons. And then this just shows you the variety of treatments we allowed on the trial, from SBRT 27 gray and 3, it was our standard regimen, to a gray and 1. So for our primary endpoint, it was significantly different. The event rate at 1 year, which is the primary outcome, was at the lesion level. So the patients could have multiple lesions. Most of them had one, although about 20% had two. And the lesion level event rate was about 30% versus 1%. But there was a criticism that radiation for pain alone might be, is that sort of justify treating a lot of patients early. So when you remove the radiation for pain, and you just look at fractures, cord compression, and instability, you get this 0% versus 14% number at the patient level. And that was still significant. And that you'll see has sort of informed the phase 3. We also did a sort of exploratory look at the high risk feature to understand which of these locations or types might be relevant, and that was significant. So meaning probably some lesions are at higher risk than others, but the actual numbers were quite small to draw any conclusions from this. We also looked at overall survival as a secondary endpoint, and we're honestly a bit surprised to see a difference. And that's, this probably is what got NRG excited, in particular to test this question again in a multi-center setting, but a median survival of about 1 year versus 1.6 years in the radiation arm. When we did a multivariable analysis to try to understand was skeletal related events on that pathway from, radiation treatment to overall survival being longer, it looked like it was. It's included as a time varying covariate, it's called, and that was significant. And when you look at include those other factors in the model, the study arm itself remains significant on a multivariable model as well. We also looked at hospitalizations, which were reduced, although not super common, 0 versus 4. And then we used the brief pain inventory as the patient-reported pain measure at baseline 3, 6, and 12 months. And you can see that was significant with sort of emerging differences over time. And the adverse event rate was low. So we just presented this at ASTRO, which was sort of a breakdown of, this actually we presented, it was in our paper. The overall global quality of life using the EQ5D was not significant between the groups. Although you can see there's differences in what's happening across time, where the radiation arm maybe early does a little bit worse and then later does a little bit better. So in this recent secondary analysis that's now just accepted as a manuscript and we had presented at ASTRO, we looked at the 5 sort of subdomains of the EQ5D to see, can we learn something from a little bit more granular information? Because there is these quality of life measures can be, by encompassing everything, it can be hard to determine what, differences between groups. And we did see on this sort of unplanned analysis that self-care was significantly improved in beyond 6 months, while anxiety and depression not statistically significantly different. That was the thing that was really driving our radiation being worse in the short term, which makes a little bit of sense to me in terms of the sort of reflecting the experience of radiation and the immediate aftermath. It is visits, it's potential symptoms, and so it's not totally benign. But this sort of also has contributed to us thinking well, maybe you really do need to survive 6 months to get sort of patient-reported outcome benefits. I mean, we saw that with the brief pain inventory as well. Even though a lot of the events happened within 6 months, which, there's competing hypotheses on, it could go either way, to be honest. But from a patient's perspective, you may want to live longer in order to benefit. So, our conclusions, this was the first randomized trial, big differences, promising new indication, but need more data, particularly to understand overall survival. I think that secondary analysis also gave us a little bit more like that maybe functional status is what is contributing to the prolonged survival. But we technically don't know. And then is radiation associated with this sort of early distress, but preserve functional status in the long term beyond those 6 months. So quickly, I'll take you through the phase 3 trial that is ongoing and enrolling rapidly it is currently open, unfortunately, only in the US and Canada. And the goal of this was to really say, is this true also in the community-based, the real community-based setting, multiple centers across, the US and another country, trying to focus on it is an NCORE trial, so that's the NCI's community oncology research program that are mostly community-based sites. Is overall survival benefit confirmed, and what more can we learn about who benefits? So we put together a study team. The trial ultimately was approved and activated in April of this year. I won't belabor, the details are honestly very similar to the original phase 2 trial. One-to-one randomization, there were talks about equipoise, should it be 2-to-1? Ultimately, 1-to-1 gives you the strongest ability to answer a question with the fewest patients. And the medical oncologists certainly have less issues with equipoise than probably the radiation oncologists. We included bone modifying agent use just as a stratifying, just to make sure it's equal, because we do know that it can affect skeletal events and survival. And then we removed radiation for pain alone from the primary outcome. So it's really powered to that lower event rate of like 0 versus 14% that I was telling you earlier. And then we included some heterogeneity of treatment effect by histology, bone modifying agent use, radiation dose, to try to better understand who benefits, then pre-planned analyses of these EQ5D subdomains. So again, the patient eligibility did not change, except based on the feedback and the number of lesions that are sort of feasible to treat, at least in most of our US centers. Up to 3 bone mets could be enrolled and randomized. This is just sort of a basic picture of our sort of highest, our assumption, or our hypothesis, the highest risk being the junctional spine, the hips, and potentially the long bones, and really weight bearing. And then we limited to the regimens that were no more than 5 treatments, because this is a preventive setting. And so the more, time people spend on treatment, the more cost to the patient, and time off of work or visits, the more, higher risk of affecting a systemic therapy. And then these were kind of the systemic therapy specifications that we included. So we did do a podcast for more information if you're interested on the NRG Oncology. Has kind of goes through a number of their trials. And then accrual, I think even last week it was up to 90. I'm like, I get the reports, the official reports, and then I get the unofficial. So it's somewhere around 100 at this point out of the 280, which is really rapid. And we've been sending out kind of quarterly updates to the group, but you can see this is, this was even before we opened it in a couple Canadian sites. So how am I thinking about this as an implementation scientist? I was kind of alluded to some issues with prediction and prognosis. I just want to kind of touch on what implementation science is and why I think these questions are critical. So really the gap, like implementation science defines the gap between when sort of a trial is published to it being available and in use in routine practice. And the NCI, the National Cancer Institute in the US, recently updated this figure for cancer-specific evidence-based practices a few years ago, to show that although, my observation as a treatment, radiation treatment oncologist was that they're leaning a lot on prevention, mammography, HPV vaccination, but you see this 15-year gap. So we kind of did a similar study with a few radiation evidence-based practices, such as showing that it can vary depending on what you're trying to implement. So we know in the US that breast hypofractionation, actually to just get over 50% of the patients to that point was about 14 years. Although it's been much faster, head and neck IMRT as sort of the extreme other example where the data emerged around the time that the report, the population-based studies actually showed that a lot, over half of people had converted to using IMRT in head and neck cancer. So certainly, I think in the treatment space, you do see a variation, and whether that's what are all the factors that contribute to that. There's certainly more challenges and probably the space of doing fewer treatments or doing lower doses. I think that impacts the bone metastasis space probably a bit as well. And then we looked at one sort of surgical breast conservation. You kind of had that same 15-year, and then it sort of plateaus because of various drivers in the US of mastectomy rates. So knowledge is really necessary but not sufficient to close this gap. That's sort of the underlying foundation. Diffusion is letting things happen. Dissemination is helping it happen with guidelines and educational materials that are easy to use. But implementation is really trying to assess strategies to make things happen. And there was a working group developed as one of the 7 kind of focuses of a 2016 cancer moonshot effort in the US that really established this area of study to really say, how do we not only do research on therapies and new treatments, but also research on the healthcare system and what are the strategies that are actually scalable, generalizable to narrow this gap? Because, many aware that we spend a lot of money in the US, but our healthcare outcomes are not, don't necessarily represent that. So the way I've been thinking about this is really this low event rate. There's that we saw in the original trial that can, generate costs to the health system. Certainly, treating a lot of patients that wouldn't necessarily be treated, and that can influence, other patients not getting treatment that need to be treated. But the patient cost too of just time, visits, and really needing to identify which of the patients we should definitely be treating. And then also being able to identify these patients so that you can then, make sure that they get access to these evidence-based practices, which would apply to bone modifying agent use basically today, since we know that there's good evidence and underuse, and potentially in the future, radiation itself. So really, and it helps to be able to do these sort of gap analyses, but also study early intervention strategies to close that gap. So just briefly, some things that we're kind of working on in the prediction space is really, one of the limitations of predictive models has been that a lot, it's hard. There's a lot of things going on and our data is not perfect. And so are there opportunities to integrate new sort of data streams like functional imaging or activity monitors, I'll talk about briefly. And then from, can we leverage AI and companies that we have one that AI Doc is already partnering with University of Washington to identify fractures on images because, even asymptomatic fractures that already exist and sort of making sure that those are identified. So can we move AI Doc into from identifying to actually predicting fractures to help us kind of early identify these patients? And then there's of 4 large cancer centers recently are working on federated learning, which really means to develop models for AI, you actually need really, really large data sets, oftentimes. And in any individual cancer center is not necessarily going to have enough data to do that. So can you, bring together the 4 largest cancer centers in the U.S., Fred Hutch, Memorial Sloan Kettering, or 4 of the largest, Hopkins and Harvard's David Farber, to pool the data for model development. And we were selected as one of the 2 projects from the Fred Hutch, and this was announced recently in Time Magazine. It's really at the stage of sort of proof of concept, but we're excited to be able to learn something about bone mets prediction in the process. And then, predict. So that's really like, there's really 2 things going on. That's predicting skeletal events and who's going to fracture, who's going to have a cord compression. And then there's the survival prediction is like related but different. We certainly know that the appropriate use of conventional versus stereotactic radiation relies on anticipated survival. I've mentioned a few guidelines here that really mention, the length of or how prognosis should impact your selection of different treatments. We know from the preliminary data from our study was that the patient-reported outcomes, the pain, the quality of life sort of suggested that maybe living more than 6 months after radiation in the asymptomatic setting might actually be the people that we should be treating more than others. But survival prediction has been like notoriously pretty challenging in oncology, including by radiation oncologists. There was a study a long time ago that I had read showing that radiation oncologists might actually be better at predicting survival, in part because than medical oncology, where in the U.S. we're definitely, we're 2 specialties, but medical oncologists follow patients longer, and so they actually develop some, biases or attachments to patients. This was like the hypothesis, as opposed to a radiation oncologist who comes in sort of closer to the end of life with a more objective view, which I thought was fascinating. But we also know from sort of some of our recent studies that we give long courses of radiation in the last 3 months of life all the time, including like up to 20% of our patients in the US as of a few years ago. And then the recent RoboMet trial, those trials used to specify the physician has to, assess survival at longer than 3 months, because often the primary or important secondary outcomes are at 3 months. And despite that, the RoboMet trial had like 25% of patients die by 3 months, or mostly die, but also some lost to follow-up. And so just kind of highlighting that, which really limited, because that study was comparing SBRT to conventional, and a lot of our learning has been that SBRT is beneficial more in the long term. So just kind of highlighting the challenge of survival prediction. So I put here kind of like our existing methods, examples. We use ECOG, KPS, and then there's this TEACH model that's actually, pretty robust to a lot of different inputs, although it doesn't really stratify patients as well as you would like to see. It kind of pulls out the few that are really in this worst category, but it's cumbersome. These things are not, there's no like easy way to pull all this data from the medical record. And our physicians doing this routinely in their practice. There's some increasing evidence for patient-generated data increasing the accuracy of these predictions. So I just was invited to review and comment on a systematic review of multiple trials looking at the patient-reported outcomes and their association with overall survival. And it really is, there's a definite association. And if we collected patient-reported outcomes routinely enough in routine care, you could start to build these into models. But our collection is not complete for a number of reasons. I highlight here one that I think is kind of a good short option is like the patient-reported ECOG, because although some studies are mixed on this, it gives you probably a complementary look to the physician-reported, just because sometimes I think physicians, we assess ECOG without actually asking the specific questions, which the patients are answering the questions to give you more information. So that's sort of like a patient-reported approach. And then the other one is really step counts. And, we know that the other classic PRO that came up in this trial that I know Dr. Barry's been um, working on collecting data is um, the C30, where then there's the sort of PAL 15, sort of 15 questions was developed for the more palliative setting, EuroQL, sorry, and this idea that 30 questions among people at the end of life really was shortened to 15 because the response rates do go down. The actual, people's ability and motivation to complete surveys when they're ill is more challenging. And so we know that data collection as people get sicker is more challenging. And so can kind of more passive data streams like step counts from activity monitors, can they also, so Dr. Ori is at Einstein in the US, and he has done some early work on really associating step counts in advanced lung cancer with hospitalizations and overall survival. And this study actually showed that it was a better predictor of survival even than physician reported KPS. So kind of hypothesis generating, like can we pull in some of this more passive data into routine data collection and incorporation? But still much to do. And ultimately, what we really need are very precise predictive models. And that is, I think where a lot of the challenge lies. But kind of to summarize, what I've been mentioning, I put here kind of we know how radiation is effective for treating pain, but can we use it for prevention? And if we do move into the preventive space, how can we really identify the patients that benefit both from identifying kind of high risk and skeletal events, but also looking at life expectancy. And with that, I will stop and see if people have questions.
Thank you so much, Erin. That was fantastic. We have a lot of similar thoughts, and it's great to hear you speaking about them. I will start with some questions, and then hopefully some will pop them in the chat because I know I've had similar discussions with some colleagues that are on the call anyway as well. So hopefully they'll add with their questions. So I guess maybe firstly about the trial, and really excited. And I have to say I was so excited to see the potential overall survival advantage. And I was trying to think about it in my own head as well, like what is that because of? And I think you're right in saying that, you see the benefit, I think, further out, and it probably is about better quality of life. And maybe that measurement it's such a difficult measurement to collect that we're not seeing it. Had you any other thoughts, or have people come back to you with other kind of hypotheses as well regarding that?
Well, yeah, I mean, just like preserving someone's ability to be mobile. I mean, I think there's so much evidence around sort of physical activity, and as you become, becoming deconditioned after a major event can really, change someone's trajectory. But like the other main hypothesis has really just been like, does treating even one lesion, does it affect cancer burden? Does it have some, I mean, I hate to say abscopal, people haven't really mentioned that, but does treating cancer even in one location, how is it impacting the overall? So that's kind of the leading competing hypothesis. So we have looked at, so the phase 3 trial is collecting blood samples to be able to see, like, can you actually look at things like ctDNA loads, before and after treatment? My assumption is that these are generally, there's so much disease and we're treating such a small amount of it that that's not what's going on, but that would certainly be another potential avenue, I suppose.
That's
And
cool
I'm
to
curious
see.
if if people have other thoughts from the
Mm.
group.
And I guess you talked about it as well about the pros and the electronic applications, and so So on, what have you learned in kind of your trial designs and development and running, I guess, of integrating firstly pros and then also integrating things like electronic applications in general as well? I know you've written on that too. So maybe they're two separate and then two together. How have you adapted for patients with that from your experience and feedback, I guess, from them too?
Yeah, I think the integration of the patient-reported outcomes is I think there's this tension that I struggle with too, which is often the validated research instruments are long and often multiple questions asking similar elements of a specific domain are the kind of most rigorously tested in order to get sort of the most accurate assessment of a specific domain. And so the challenge is like if you're presented with, in the research setting, we do tend to lean on more of the validated tools. So, if it takes 10 questions to ask about fatigue, as the sort of brief fatigue inventory, we will use that in the research setting, even though that means that you've now burned 10 questions asking about one symptom, which, gives me anxiety because I'm like, there's that 10 questions could have given you such a more diverse look. But, that's kind of where in routine care, we've kind of tried to limit and maybe, a lot of these one or two question um, are tend to be used more as screeners to then like if they screen positive on one or two questions, then they give them a longer questionnaire. There is some work I'm like collaborating with a psychometrician on something called like item response theory, which is trying to take some of these longer tools and make the individual questions at least validated for use. So if you say the QLQC 30 is like 30 questions and you're really not interested in like, you know, a certain subset of them, that it would be acceptable to omit them, because that's what the PAL 15 kind of pulled out some and then went through a rigorous validation process. And so you can use that,
Hmm.
but you're really not supposed to just pull out a couple questions
Hmm.
from a validated set,
Hmm.
because that, risks the validity of those questions. So I think that there's opportunity to develop, shorter questionnaires, and there's just got to be a lot more emphasis on doing that because in the modern day, like people are getting tons of surveys, and the longer they are, the less likely they are to fill them out, particularly on
Yeah.
an ongoing basis.
Hmm.
Um,
Do you use
those,
anything in
and then,
particular as baseline in your own clinic? Like, do you use ESAS as a screening tool, or do you?
well, that's an interesting, yeah. So ESAS is one that I like because it's
Hmm.
10 questions and it's like
Hmm.
one for each, and you pick the 10th one. I think that that's actually a good one. And then it gives you sort of a symptom, um, sort of distress score overall.
Hmm.
We had been using the PRO CTCAE,
Hmm.
because that was kind of NCI had just validated it with Memorial Sloan Kettering, and it does allow for branching. So if fill out, if you answer, it was like
Hmm.
7 to 14 questions during radiation, and we were doing that in breast cancer specifically,
Hmm.
that you can assess 7 symptoms, and then it'll go to 14 questions if they're having symptoms that lead to
Okay.
more. So the electronic nature certainly allows you to do more of that branching, which probably helps.
Hmm. Okay.
Electronic has, pluses and minuses, but overall, I think moving into that just helps with data collection and reducing costs and
Hmm.
accessibility of data
Hmm.
for particularly immediate action.
Hmm.
The other thing I was just going to say is just making sure to think in advance about languages. I mean, it can be cumbersome, but we were literally right now, we had added a health-related social needs screening to the baseline
Hmm.
for the NRG trial, just to collect additional information about this, the sociodemographics and barriers that our patients have. But
Hmm.
we didn't specifically include the other, the at least Spanish and French, even languages in the
Hmm.
protocol. And so, although we had done that for the BPI and EQ5D, and so we're like amending the
Hmm.
protocol to include that. So it's like you can
Hmm.
even just it's just so easy to, but when you have the opportunity and the ability to distribute multiple languages, a lot of the validated surveys, fortunately, are available. So you
Hmm.
don't lose data on that, of course.
Yeah. There's some questions coming in, and I've one or two questions as well afterwards. So
Sure.
from Dr. Lyons, who is a radiation oncologist, I logged in a little bit late, no worries, Kira, don't worry. How are you approaching these patients in your practice? I'm assuming, Kira, you're talking about the high risk fracture patients, and are they being referred to you, or what does that look like on a day-to-day basis now that you've run the phase 2 trial and going into the phase 3?
Yeah, it's a very common question. I think the reality is that there are going to be patients that people were kind of already on the fence about whether they would treat them or not. And probably a phase 2 trial gives you a little bit more confidence to do that. Although, you know, the reality is that we still don't really know if every patient that meets those eligibility is going to benefit. So that's why, like, if you have the trial open, it's the optimal setting in which to offer that to a patient. Um,
But were you going to, did you have specific fracture clinics? Like we've been trying to think about how we would implement it in our own clinics as well. Like, did you have specific clinics? Did you do a Gillian Tsai in it and go through CT scans and CT scans to try and find patients, or what did you do?
Oh, yeah, Jillian's, I feel like it was PET scans that she was looking for and she
Hmm.
like machine learning on oligoprogressive
Yeah,
language,
yeah,
even, and then at some point just manually looking at the
yeah.
reports. Um, we've kind of toyed with this idea. So the reality is I guess I didn't really get into this. That was one of those bullets was about 2/3 of the patients on the phase 2 trial were from within radiation oncology. So that means they've already been referred
Mm.
for a symptomatic site or they're in follow-up for something that was treated. So on the one hand, so that's kind of what I think 90% of clinics have been leaning on for treating and enrolling to future trials. I mean,
Okay.
we have definitely informed our medical oncologists about the phase 2 and the open phase 3 for referrals. Um, and we are in the process of getting sort of those trials listed on they have med-onc research coordinators that identify when patients might be eligible or try to help
Okay.
physicians. Um, but I mean, in the short term, we're running into enough patients that are within radiation oncology already to enroll and treat. And we're not necessarily like, particularly for screening to refer patients. There is, I mean, I think the trial benefits from having some of those sort of referrals for patients that would have otherwise not been sent to radiation oncology.
Hmm.
We would benefit from learning from that because one of the criticisms was like, is this really a trial for my stable metastatic prostate patient who like has been
Hmm.
asymptomatic and probably will be for years, right? Like it
Hmm.
probably doesn't apply to that person because that was a pretty small percent of the people that were on the original trial. So
Hmm.
we would benefit from a wider variety of more of those sort of referred without other reasons to come to radiation oncology.
Okay.
But on the other hand, those also may not be the ones that
Mm.
are most likely to benefit. I mean, one hypothesis that we've developed is that like you probably do need to be in some sort of, there's like the Goldilocks of like you need to probably be progressing a little bit or at like
Hmm.
some pace in order to like not just treat someone who wouldn't nothing would happen for a few years.
Hmm.
Because like is radiation going to impact 3 to 4 years later?
Mm.
Hard to say, but like
Mm.
and you don't want to be progressing so rapidly that you're like in
Mm.
your last 3 months of life probably.
Hmm. Yeah.
Um,
Yeah.
but yeah, so we haven't
Okay.
done any formal, we've definitely talked and considered
Mm.
and applied for some grants to, try to screen radiology reports.
Mm.
One
Mm.
of the most, and some of our community-based sites have also tried to even get the radiologist to addend reports to say
Hmm.
like, this
Yeah.
is by, our
Yeah.
definition, a high-risk lesion, but that has not
Hmm.
been ultimately it's more work for the
Hmm.
radiologist and it's not been kind of
Hmm.
successful. we have had a couple sites that have just really strong medical oncology partners that are
Hmm.
engaged and reviewing and referring patients. And there are some of our highest accruing sites because the
Hmm.
number of patients in medical oncology that are eligible is very
Hmm.
high. I mean, we have some data from our
We've
own
very strong
retrospective
palliative
studies on
care
that.
actually in our group as well. So, they would see a lot of these patients too, which is great. Yeah. In terms, so I see
Yeah.
Kathy also has a question there. So Dr. Rock is also a radiation oncologist. So how were systemic therapies managed during radiotherapy in the trial? Was there a very specific protocol for many different agents and that the patients can be on?
As like a mostly single institution phase two, we just said per physician discretion because we kind of had some internal guidelines on, when to stop radiation during certain medications. Um, we published that in a consensus guideline. The irony is like from our MSK Cancer Alliance that had a little bit more detail around different agents. In the final NRG protocol, that's what I showed you. They had us kind of just simplify rather than even referencing the guideline, which was like hormonal therapies are safe to continue.
Hmm.
Immunotherapies are probably safe to continue, but when in doubt, stop for, the days that you're on treatment, in particular. Obviously there, and consider this sort of two half-lives if you're really concerned about the overlap of an organ with where the radiation is going to
Hmm.
go, as
But I assume in
the
general
most
for arms and
conservative.
legs, and those kind of things would be okay. I assume for
Yeah,
the rest of
right,
them.
because there's not like you
Yeah.
don't have like the spinal
Mm,
cord or like the bowel right next to it, where
mm,
those are probably like highest concern.
mm. Interesting. I have another question, and I'd say we're nearly there to wrap it up. Uh, the federated learning, that sounds so cool. In terms of data protection, so that's something that's really, really topical here at the moment. And we don't have national data protection, so we have to go through different data protection groups if we're to do or share data or whatever. Do you have a more national, or I guess it's probably a state? Data rights, or how do you approach that in terms of consenting patients to share their data on this big national basis?
Yeah, so that's like the how this is supposed to work, which this is actually being funded more by like Microsoft and Deloitte and like companies, like industry partners that are
Hmm.
interested in establishing because it in order for us to share data across institutions, we are not including like we are taking away the PHI. So it's sort of like establishing a way to share data that like is limited in that you're not actually just it's not like you have a data use agreement between
Okay.
multiple institutions and you're sending data back and forth. You're sort of
Hmm.
using data in sort of like a safe central space that does not include PHI. And so it's complicated, but the idea is like, yes, that will make it more scalable if it's possible to develop the kind of technology to do that, to
Hmm.
that you would get away from a lot of the concerns about the patient privacy.
So are you
Yeah.
consenting each of the patients then to be part of that? Or no, it's whatever they've consented
No,
to in the
because
clinic,
the
right? Okay. Okay.
like
They don't think the
no
risk
data
is
is like leaving the
okay.
institution that is sort of protected essentially.
Oh, interesting. Okay. 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 And then I have one last question. You wrote a paper recently about integrating ePros as a tool to recognize patients for clinical trials. And so there were patients, if they had like a certain symptom, that would
Hmm.
flag then that they could be potential for clinical trials. Is that something that you're using on a regular basis? Or is that
Yeah, that was for a trial that was looking at like an integrative medicine intervention for fatigue. And so,
mhm,
yeah, we were literally collecting all this PROs during breast radiation, and fatigue and anxiety were the two that were kind of the most commonly flagging positive without
mm,
sort of specific interventions that we could like offer patients, other than kind of like our routine, like, oh,
Mm-mm.
you should exercise more, or
Mm-mm.
we can offer like a social work consult. So that was an automating like if you had a
Mm.
moderate level of fatigue on the PRO CTCAE, which was sort of like the baseline screener, you would get information about a trial for an intervention, a remote intervention for fatigue. And
Mm-hmm.
that's so, and that was just
Yeah.
wildly, because we had like 40 radiation oncologists treating patients with breast cancer,
Mm.
and a lot of them were not even aware of that trial that was in a different
Mm.
department that was
Mm.
going on. Although
Mm.
we had sort of done the standard kind of
Mm.
monthly, it was in the emails and the conversations, but
Mm-mm.
people are busy and there's just an unlimited number of
Yeah.
trials. We are in the process, honestly, and I've moved to a new institution, and both institutions have actually changed their medical record. So University of Washington moved from they had their own PRO and like EMR to Epic about 2 years ago. MSK is now making the transition to Epic just this past 6 months. And so kind of reinstating PROs during routine care is like
Mm.
just making those EMR transitions. And
Mm.
then, once, it's sort
Mm.
of in place, coming up with strategies to I still think there's honestly a little bit more to be done to say like, are there certain, I mean, because you can start to inundate people with a lot of my, Epic,
Mm-hmm.
my chart messaging about things that like
Mm-hmm.
may or may not be, so it's sort of a slippery slope that
Mm-hmm.
it's the same with survey questions. Like if you get
Mm-hmm.
10 invites, so you have to be somewhat careful. And I think there's
Mm-hmm.
an opportunity to do more of these, yeah, larger scale, like
Mm.
using PROs to refer to a
Yeah.
number of different trials and try to
Yeah.
learn like what should be the escalation measures when they don't
Yeah.
respond, and like,
Yeah.
how do we do that effectively? But yes, I think that there's certainly increasing,
Mm-hmm.
evidence to suggest that like developing systems, and honestly, a lot of the times the barriers, there's, we have these sort of quality metrics for kind of distress screening, at least at intake, around social needs, and um, oftentimes the barrier is just not enough of the supportive services to
Mm-hmm.
provide an ethical, one thing that comes up is like, well, if you don't have it's not ethical to ask about things that you can't immediately
Mm-hmm.
act on with
Mm-hmm.
services. So,
Yeah,
that would
exactly.
be a question for like your palliative program. If you were
Yeah.
asking people about pain or some functional,
Mm-hmm.
and you wanted to refer them to palliative, would they have the bandwidth to
Mm-hmm.
actually see more of those automated
Mm-hmm.
referrals?
Mm-hmm. Yeah, no, it's fascinating. But like, if there's any way that we can try and increase our accrual to, especially radiotherapy trials, I feel a
Hmm.
lot of that is about education, about engagement, and I thought that was particularly interesting. But Erin, I think that's it. I don't have any other questions. I don't see any other questions on the chat other than thanks for your time and interesting
Yeah,
talk.
thanks so much for
And
having me.
no, thank you so much. It was great. And yeah, we'll stay in touch. And thanks again for taking the time. I hope you
Great.
have a good day.
Take care. You too.
Thanks.
Bye.
Bye. Thanks, everybody. Bye.